A pinch of posterior segment insight is our next topic, and it's moderated by Professor Gemmy Cheung out of Singapore. She's speaking first to tell us about visual changes in COVID recovered patients on OCT angiography. Are those real or imagined? After that, fluid atrophy and fibrosis in wet AMD by the illustrious Professor Mark Gillies from Australia. And third up, post-COVID-19 sub-retinal abscess by Dr. Alay Banker out of India. All right, let's sift right through these presentations, shall we?
Thank you, and welcome to a pinch of the posterior segment. My name is Gemmy Cheung. I'll be moderating this session with my two good friends, Professor Mark Gillies and Dr. Alay Banker. So I'll start by sharing my slides, and today we will have two talks, in fact, discussing COVID-related posterior segment findings. So first of all, here is a question mark. COVID retinopathy, real or imagination? Now we know that we know about it. This endemic, and it's affecting pretty much everybody. And this paper coming out at the earliest stage of COVID infection from China described that true COVID can affect the eyes, but mainly in the anterior segment, affecting the conjunctiva. And until then, there is very little known about this infection in the posterior segment. Subsequently, there's this quite well-known publication as a letter to the Lancet last year, describing a case series of healthcare workers who contracted COVID, and it describes certain signs, including cotton wool spots, as you can see, some microhemorrhages, and also some OCT hyperreflective findings. So this may be quite important, and yet at that time there was a lot of criticism because some of these OCT findings were felt to be possibly just due to normal blood vessels, and so that really brings a lot of unclarity to whether this COVID microvasculopathy is real or imagined. Now, if we want to establish whether there is such a relationship, there are a few considerations we need to look at: cause and effects, or whether association, even if it is observed, such as some of these considerations, and I won't go into each in details. Now, what I looked at, this is almost a year since that Lancet initial publication, and by now I just did a search on retina and COVID or SARS-CoV-2 last month, and this returned 203 articles. I sifted through all the correspondences and looking through only the articles with actual data, and I would like to highlight or summarize to you 26 articles, and these include 9 case control studies, 6 case series, and a few case reports featuring COVID-19 and retinal findings in the posterior segment. Now, retinal microangiopathy signs. This was evaluated in 11 publications, including 5 case control series, case control studies, and 6 case series. So in the case controls, we actually now have accumulated only in the literature over 300 cases and over 260 controls. The kind of things that have been described, the features, are mainly hemorrhages, microhemorrhages, and cotton wool spots, and also dilated or tortuous vessels. These were described in 4 out of 5 of the case control studies. And when we pull these together, we found that actually there was a significantly higher prevalence of cotton wool spots when we compare the cases versus the controls. Whereas for hemorrhages, there was numerically higher reported, but this did not reach statistical significance. Though there seems to be a consistent theme here. In addition, so these are some examples published by the Italian group, and Alessandro is a good friend and also an ex-fellow of Professor Mark Gillies. So here, as you can see, these are the kind of features they see: venous dilatation, microhemorrhages, cotton wool spots, and very important to have a control group here to know that these signs are not just purely observed coincidentally. This is a paper out of the Singapore group, including myself, and we can again see similar kind of themes, tortuous vessels. And importantly, in this case series with 108 participants, these are all young people with relatively mild infection that did not require hospitalization and no need for oxygen support. Of course, there are the case series that involve more sick patients, and in these cases, the question of whether it could be the treatment or such as ventilation or the anticoagulant therapy could have induced some of these features as well. So when we look at these publications, also important to make a note of what is the background status of these kind of patients. In terms of the underlying pathophysiology, I think in addition to the clinical observations, we now also have imaging data which study vessel density and FAC, and reported in 6 out of 7 such studies that there is a reduction in mean vessel density on OCTA. And in addition, one study reported dilated mean vein and artery diameter, again consistent with a kind of hypercoagulability state. So again, in keeping with those clinical findings. Now, this is one paper that really hit me, published in the Canadian Journal of Ophthalmology, because these images are so striking. Up top are 2 images of recovered, apparently COVID infected patients or participants compared to controls down at the bottom. I mean, if you don't tell me, if you just look at those OCT angiography, I would have thought that these come from really badly controlled, long duration diabetic patients with significant microangiopathy. And yet these are patients pretty young, honestly younger than me, that's very young, with hardly any underlying medical condition, very little in terms of needing any oxygen support, etc., apparently completely recovered from mild COVID. So the situation is how true this is and how commonly do we actually see this if we go and look for them in patients as well. And of course, in sicker patients, and it's been reported that in patients with higher D-dimer, they tend to have more of these features as well. But in fact, to me, I think it is the well patients that are found to have these features which worry me. And this is the other studies showing that in addition to the OCTA features in the macular area, you can also measure the central artery and vein diameter, again in keeping. I won't go into too much details about the individual case reports because these tend to be uncontrolled, but many of them, or a few of them, reported retinal vein occlusion or PAM, again, so in keeping with the general theme of perfusion issues associated with COVID infection. So is there a biological evidence or basis to support these findings if indeed they are consistent? Well, there are 2 series. One is, for example, as you can see in this paper, they looked at donor eyes with COVID and compared with control subjects. And in a number of these eyes, they demonstrated in these retinal flat mounts of diseased patients that there is severely reduced microvascular density. So in keeping with what we've observed on the OCT angiography, and in terms of the underlying pathophysiology, it's been suggested that increased inflammation may be one of such mechanisms leading to these changes. In another study, they looked at the ocular pathology of 10 eyes, again from deceased COVID patients, and reported evidence showing hypercoagulation and vasculopathy due to endothelial damage. Here they show swollen endothelial cells and fibrin microthrombi. So these are actually in keeping with what we observed on the OCT angiography and the clinical features of microaneurysms and cotton wool spots as well. Now, whether these are due to a direct infection of the local cells inside the eye, or whether it could be a more generalized hypercoagulability state is still another question. But nonetheless, both can be linked back to the COVID infection itself. So in summary, I think I would open this discussion to my 2 friends here. What do you think now? COVID microvasculopathy. Do you think there is more to it? And if so, I think my concern is we know that there is almost 200 million people infected with this now. And even if it affects 10% of those recovered population, it's going to be a huge cohort of people. Now, if they have an OCTA like this today, we need to know whether it's going to recover or it's going to get worse. And if this person is 40-year-old today, in 10 years' time, a lot of them are going to also acquire additional conditions such as diabetes, hypertension, and what will that do to the retinal microcirculation? So I think as a community together, this is a very interesting and topical area, and then maybe opportunities to work together to do some sort of large-scale, well-controlled longitudinal studies. So that is my little pitch of the posterior segment. And thank you. I'd like to open this for discussion. So Ali, you're going to talk to us about COVID infection, another kind of manifestations later on. Maybe I'll start with you. What do you think? Have you had any personal experience looking at the retina of COVID with this kind of milder manifestation, and do you think it's real?
Yeah, I mean, a very nice presentation, Dr. Cheung, and we've seen many of the cases exactly like you published, and more so in the recent last 1 month. As you all know, there's been a huge wave of fungal infections, particularly mucormycosis in India. And, most of the younger patients, as you said, who were not on any treatment, they were just home quarantined. They had very mild infections. They did not receive any kind of therapy. They are actually getting panicky, and they are coming just for an ophthalmic retinal screening examination. And they come to me and say, doctor, just check my eyes. Do I have mucor? Do I have this black fungus, what it is known as? I mean, today itself, I've seen 4 cases in the morning. It's absolutely normal. They are asymptomatic, but they just come for the screening. And many of these patients show these kind of dilated tortuous veins, and there's nothing else. But I'm sure that there is a real microangiopathy which is going on with this kind of infection. And it remains to be seen whether it is truly reversible, and if so, how far it is reversible, or as you said, 10 years down the line, does it leave any residual microvascular angiopathy, occlusions? And these are common in other parts of the body, like in the lungs, it's basically a microvascular occlusion. And I think we are seeing that in talking to nephrologists, they are seeing that in the kidneys now, having these micro-occlusions because of the virus itself.
Yes, thank you very much for sharing with us, because I think we're still learning so much more about this infection from early on, thinking that it is mainly a lung infection. Now we know it affects the heart, affects every part of the body. Thank you very much. And we look forward to more from you on the even more scary spectrum of COVID infection. What about you, Mark? What do you think?
Well, yeah, we haven't been seeing a lot of COVID here in Australia, although we do have a breakout now in Sydney, and we might have to lock down in a day or two. But apart from that, no, we haven't seen a lot. I was interested, yes, what about the other systemic manifestations like proteinuria, peripheral neuropathy, these sorts of things? Have they been described? With proteinuria, that would be fairly easy to detect if people screen for that.
I haven't looked into that systematically. I suppose the other issue is, for example, the timing of the examination. So there are some, most people are like grappling to control the acute state of the disease. So for example, when the patients are in hospital, I'm sure the kidney function, even the existing diabetic control of the existing diabetic patients, everything goes haywire. So there is that population. But if they are then discharged and apparently the acute phase of the COVID is settled down, and whether they continue to have other problems, and whether that is directly attributable to COVID itself, or people just say, oh, just because they've had a bout of illness and it is not specific to COVID. And so I think that will be quite difficult to tease out. But if we move forward, Mark, you've conducted so many large studies. If we were to examine this and have a more clear direction so that we are not saying whether we're picking up coincidental findings or findings that are not specific to COVID, but it's just because they have other medical problems. How do you think we need to plan such endeavor?
So this was, well, I guess you'd have to do some sort of, ideally you'd do some sort of geographical cross-section or a hospital-based cross-section of all the people who come through. Not everyone's going to have diabetes, obviously. Yeah, the outcomes, we're more into outcomes research. That's more, you'd have to ask Paul Mitchell about how you'd survey for that.
Okay, the thing is, at the moment, the healthcare system is pretty tight, just managing the acute disease. And there is segregation as well. So in our hospital, we're doing team A, team B. We don't want the doctors to cross-infect. Plus, we're telling patients to try not to come to hospital unless it's serious. So there are some significant...
Not normal. Those images, angiograms that you showed are not normal. If they're occurring in otherwise people aren't diabetic, I don't really think you need controls. That's just not normal.
Were they symptomatic at all? Like the patients who had these dilated tortuous veins? So how did you pick them up? How did you pick them up? Why did they turn to your clinic?
So those are actually series. So a continuous series of infected patients, and some of them are just recruited as a case control studies.
Okay.
Okay, so thanks for that interesting discussion to start off our session. So I think we'll move on to the second talk, which will be given by Mark Gillies, and the topic is going to be
fluid fibrosis and wet macular degeneration. I'll just share my screen.
Thank you, Mark.
Hold on. Matt wanted me to wear these glasses, but I can't see the damn thing with them, so I have to use these. And so here's a case of someone that I've been following for many years. She was on anti-VEGF treatment here, 80-year-old woman. She was famous. She was in a video of the Governor General when he got drunk at the races. Anyway, this is her macula in 2016. She'd been on injections for 5 years by now, and you can see all the atrophy that she had there, and this is a progression that she had just over the next year. And here's the other eye. So here's someone who's, and I've treated her. You can see on this is the FRB graph here. This is the treatments along the bottom here. So she's had Lucentis in her left eye here all the way since 2010. And so I'm wondering, are we going to stop this or not? Because I'm feeling that I'm causing the atrophy. So this is a question we've all got. These eyes, she never reactivated. She's been inactive all the way through. I extended her out to about three monthly treatments, but in the end, I thought maybe I should stop this treatment. So what are the evidence for doing this? And I'll go through this today. These are my disclosures. So here she is. We stopped the treatment, and 2 years later, she recurred. And here it is. So she's still got this atrophy, still got the fovea in place here. She's got subretinal fluid, doesn't have any much intraretinal fluid here. We gave that a treatment. I saw her 4 weeks later. So what are we going to do now? Every time you see a patient in the clinic, you give them an injection. If you're doing treat and extend, the management decision is when am I going to see this patient next for the next treatment? So I didn't treat that. I left that alone to see when it would come back. And 2 weeks later, here it is. It's starting to recur again. So we know fluid is very, very important, whether you do treat and extend or PRN. And mostly, at least when we started, what we want to do is get rid of the fluid. And all the retreatment decisions we had were based on this. So what's FRB learned in terms of atrophy, fibrosis, and fluid? So we did a study here on atrophy, the long-term prevalence of atrophy in patients who'd been treated for up to 9 years, and it increases to about 42% at 5 years. And it goes off a bit after that. The rate slows down a bit to about 50% at 5 years. When you have a look at the main risk factors for the development of atrophy, it is a dry lesion. So if we split the lesions up into quartiles and we compared the atrophy rates in the driest lesions versus the wettest lesions, the driest lesions were 4 times more likely to develop macular atrophy than active lesions. We couldn't tell between subretinal fluid and intraretinal fluid at that point. So we were thinking then, well, maybe we don't need to get rid of all the fluid. If you have a look at fibrosis, on the other hand, this was something that Kelvin did when he was doing his fellowship with us. And again, you can see here that the rate of fibrosis is fairly flat. It's about 25% for the first 5 years and starts to increase after that out to 10 years to about 50%. In this case, when you divided the lesions up to dry and wet, the wet lesions now are more likely, not a lot more likely, 1.6 times more likely than the dry lesions to develop atrophy. So you're walking a bit of a knife edge. If you do it too dry, you're going to get atrophy, but if you let it run, then you're obviously going to get fibrosis. Here's another interesting study we did in 2015, where we looked at, we broke eyes up into just how many visits they'd had that were active or inactive. And the top left quartile, you can see that was dry all the way. The bottom right was wet all the way. And you can see the mean visual acuity change amongst the 4 groups was pretty much the same. There wasn't much difference. And atrophy the fluid didn't seem to be making a big difference to the outcomes over the first year, which surprised us, but we didn't make a big thing about it because we didn't understand it, but we reported it, got in the BJO. Now, this is another study by Kelvin, who did a lot of work, very productive when he was in Sydney. And this is the impact of disease activity on the 5-year outcomes. We extended the 1-year outcomes to 5-year outcomes. So we stratified the activity again into 3 high, moderate and low activity groups. And this eye, for example, would have these active and these inactive visits at 56% active. So that's mostly active eyes. And these are the proportions that we used to divide them up. And turns out the visual outcomes, again, like Goldilocks, not too wet, not too dry, just in between. So if you have a look at the visual acuity outcome over time on the left here, the mean visual acuity change, then you can see they all increase for the first year or two and it wanes. However, the eyes that the moderate level activity had the best outcomes, better than the low activity in green and better than the high activity in the red that did worst of all. And the gains in the, there's a significantly greater 10-letter gain in the moderate activity groups. Interesting, these groups again, so you can see that the low activity groups had the higher incidence of atrophy, 56% versus 26% of the high activity group, and they had a lower rate of fibrosis, 27% versus 41% in the high activity group. And same way around. So we conclude from this that, you know, it looks like allowing a bit of fluid gives better long-term visual acuity outcomes, and this is likely to be related to the differential development of subretinal fibrosis and atrophy in highly dry or highly wet eyes. And we believe that some degree of activity may develop against the development of macular atrophy. What about the location of fluid? As you know, Kat found that if you had intraretinal fluid at the fovea, you were more likely to develop macular atrophy, but if it was subretinal, you're about 1/3 as likely to develop the atrophy. So they've found the same thing. The fluid study run by Robin Guyon and Jenny Ireland, the randomized clinical trial, as we all know, the relaxed treatment regimen had similar visual outcomes to the intense regimen, the relaxed regimen allowing subretinal fluid. So finally, this is the what we've done now, the association of subretinal fluid versus any or intraretinal fluid and the outcomes there. So if you have a look at if they have subretinal fluid or subretinal fluid only or intraretinal fluid at baseline, they tend to have similar visual acuity outcomes over the first 12 months. However, in the top right graph here, you can see that the visual acuity outcomes for mostly inactive eyes in red here are similar to the eyes which were mostly had subretinal fluid only, and significantly better than the eyes that had mostly active lesions. So to conclude all this, we're thinking now, and this is what we do in most parts of Australia, I think now, is we pretty much tolerate subretinal fluid. We might even extend with subretinal fluid if there's no intraretinal fluid or bleeding and visual acuity is stable. Definitely intraretinal fluid is associated with worse outcomes, we all know that. And so it's important to distinguish between these two. A big question now becomes whether you need artificial intelligence to that, or you can continue to just eyeball it. Personally, I think until that's proven otherwise, I think we're okay eyeballing it. So it's Goldilocks. Too much fluid is bad outcomes, too little is bad, and we are tolerating subretinal fluid. And these are the keys to good outcomes I think FRB has helped to establish. Good baseline visual acuity is really the key to it all. You've got to pick it up early. Where you start, because where you finish depends on where you start. Treat and extend regimen really is, there's nothing better for real world practice that we don't think there is. It allows you to give an adequate number of injections with the fewest visits. We tolerate a certain amount of subretinal fluid quite a lot these days, and we continue to treat most eyes forever. So yes, when we see our patients, the important message is I'm going to inject your eye every time I see you until one of us dies. Singapore is a strong contributor to the FRB project, and we're encouraging other people in the region to become involved. We have pilot projects in Japan and Taiwan. If anyone in the region would like to join, here's our contact emails. Be very happy to take questions.
Thanks, Mark, for that that discussion. And I will just like to, first of all, echo that the FRB is a really successful international collaborative project led by Mark and Singapore. We're one of the sites, and we really enjoyed very much as part of that. Mark, was that champagne?
Yeah, 6 o'clock.
Perfect. Goes well with a pie and cake. Now, I have a question for you. So do we tolerate, well, we know that we can tolerate fluid, but would you intentionally leave some fluid?
Yes, indeed. Oh, I see. Extend out till you get it. Yes, for that woman that I showed to start with, who was dry for like 10 years and got all the nasty atrophy, I do intend to try to have some subretinal fluid around. I want to extend it all till it comes back, and then I'll treat it. I don't want to keep it dry again. I don't want it to be I don't want it to be completely dry again.
Mm.
But then sometimes you'll get intraretinal fluid, you can't do it. But if you can get away with just a subretinal fluid, it's great. Yes.
Okay.
And I think this really warrants, this seriously warrants investigation. It's something that we can do. We can detect the fluid and we can have regimens around it, but I don't think it's quite clear what they are yet. I don't know, and everyone's agreed on an approach to this yet. We're just getting the data in, but every time you look at it, no one has looked at this and not found what we're finding.
Yeah. So Mark, I've seen some questions in the Q&A box. So one question from Kelvin is that, is there a level of subretinal fluid that you will tolerate? Is there a quantitative mark there?
It's pretty uncommon that you have more than 200 microns of subretinal fluid and there's no intraretinal fluid. That was the limit in fluid. So probably 200 microns, but it's so uncommon. You don't really. And the other thing obviously is whether the visual acuity is deteriorating. The visual acuity is stable, that's fine. If the visual acuity is deteriorating, then I wouldn't be so keen on it.
Yeah, so that was my question, Mark. I had two questions, the same question relating to the visual acuity. So I guess maybe you can tolerate any amount of fluid as long as the visual acuity is stable. Is that correct, or?
No, I wouldn't. I think visual acuity is not a great marker of disease activity. Sometimes I've noticed that visual acuity improves when lesions reactivate. It doesn't get worse necessarily. I don't think you can necessarily rely on it, but it is a bit Yes, it's not ideal if someone's visual acuity starts to deteriorate and you're sure that that's the reading. It's not just a bad reading, but it is definitely going off after over 2 visits. I probably wouldn't tolerate it then. But the thing is, you don't see that very much. It doesn't usually affect the vision too much.
And my second question is, do you really do an OCTA in a persistent subretinal fluid? And what if the OCTA shows a persistent net?
Yeah, well, I expect it probably would. And that wouldn't change. I wouldn't look for it and it wouldn't change my management. I expect there's a net there that's leaking fluid. That's where it's coming from.
That's right. Great. Thank you.
Mark, I've got another question. As you know, Usha and others have published not only on the absolute amount of fluid, but also the fluctuation of fluid. So, does that mean that if we try to marry the two together, don't let it fluctuate and leave some? So, is the idea to persistently leave about the same amount of fluid?
I think you can. It's not difficult to run eyes with a bit of subretinal fluid. Once they have it, if you stay at that interval, that generally can be is often a stable situation.
So better than trying to dry up. Sorry. Yeah, please go on.
Fluctuations in all fluid or just subretinal fluid she's talking about?
Or.
Yeah, see, that's the thing. Yeah, fluctuations in all fluid is not a good thing, but I'm not sure fluctuations in subretinal fluid is such a bad thing.
Okay. And then also related is, so we talk about fluid compartments. Do they correlate to the subtype of CNV? So particularly the type 1, they tend to have like mainly subretinal fluid, and rarely do they also have lower risk of fibrosis as well? Has that been looked at?
Good question. Actually, no, we haven't correlated the. We don't have as much data on image type as lesion type as we used to, because people aren't doing the angiograms. Although you can often call it like the OCT, but it's not as reliable.
Okay. Yeah,
that's a good question. I would suspect that. I would suspect that occult lesions would be less associated with subretinal fibrosis. Yes.
Yeah. But I suppose I agree that OCT is still the most practical and accessible to everyone. Yeah.
And is there any particular type of anti-VEGF which gives a better response to the subretinal fluid?
Well, this is the whole thing. If you want to bring that up, yeah. I mean, aflibercept dries out everything much better than the early centers every time you look at it and everything. And probably Beovu is going to do that over aflibercept, and maybe faricimab is going to do it over aflibercept. But is that a good thing or not? It might not be such a great thing. It's good if you control the intraretinal fluid, but yeah, better control of subretinal fluid is not what we're looking for. Something that lasts longer is what we're looking for, but not better control of subretinal fluid.
So there's one more question in the Q&A box from Manwai. Hi, Manwai from Malaysia. So he said, how to eyeball it, as you say, Mark? How much is too wet and how much is too dry for the SRF?
Well, any intraretinal fluid is bad. Although, you know, you see these eyes that have got intraretinal fluid, especially the type 3s, and they've got it around the vessel, where the vessel came up, and you really think, is that so bad? But I always treat it. I suspect if you didn't treat it that aggressively, you'd probably observe that. But your intraretinal fluid at the moment, we don't tolerate any of that. But the subretinal fluid, as I said, it rarely gets above 200 microns. Usually it's fairly tolerable. And it's easy to see. It's very easy to see subretinal fluid for a retina specialist.
Okay, great.
But not that much different. I don't think judging fluid is that difficult. I think the people who say that we need AI to do this, sure, that they might be right, but they've got to show it. I wouldn't necessarily just go, oh, we could just go there, I suppose, but I'm not sure we need it. I think we'd be better off working out what to do with the fluid with you know, an international consensus.
Yes, great point. Okay. So that's the fluid conundrum goes on, but I think we're getting more clarity now from more and more data. So once again, for everyone on the call, please consider joining the FRB, because you can contribute your data to this kind of wonderful educational data set that we can all learn from. All right, and then we'll move on to the third talk for this afternoon, and that will be by Dr. Alay Banker, and he is going to tell us more about COVID infection.
Thank you, Dr. Cheung. I would like to thank the organizers for giving me this opportunity to present a very nice situation, as we've been discussing this afternoon, about the various retinal manifestations of the COVID-19 infection. And to take you through, I will start with a very interesting case presentation that we had seen, a case of a 61-year-old male who presented to us with dimness of vision since about 1 month, however, had redness and watering since 2.5 months. He had known hypertension and ischemic heart disease since many years. The main important factor to note here is that he was diagnosed as COVID positive on the 6th of November and returned negative in 2 weeks' time, and was treated basically with injection remdesivir, steroids, vancomycin, and had an hospitalization for about a month. On the previous reports which he came to us with, he had a high resolution CT chest, suggestive of COVID-19 before 2 months, basically showing ground glass opacities as a sequelae of viral pneumonitis. And on presentation, his blood sugars and his creatinine and the blood counts were essentially normal. When he presented to us, he barely had light perception vision in the left eye and 624 in the right eye, had nuclear sclerosis of about grade 2 with posterior synechnias in the left eye. The posterior segment examination essentially revealed vitreous haze +1 in the right eye and grade 4 vitreous haze, which essentially did not allow us to see any fundus details, with a running diagnosis of query endogenous endophthalmitis. And these are the pictures on presentation on 9th of February. You can see the left eye, there's synechnias and +2 nuclear sclerosis, and you can see this yellowish lesion with a diffuse vitritis overlying, which does not allow us any detailed view of the retina or even the optic disc. So we had a running diagnosis of endogenous endophthalmitis, and we actually advised a primary vitrectomy, not only diagnostic, but also as a therapeutic measure. And just to run you through a short video of the procedure, and you can see these whitish opacities. They were in the form of vitreous sheets, and there were few isolated round ball opacities as well. And we started clearing the vitreous gradually. You have to be very careful because we're not able to view the retina. Fortunately, this was a dense vitreous sheet. And as we were clearing the vitreous sheet, we were able to achieve a view of the underlying retina, which looked pretty okay. But then there was an area which was a dense whitish tissues almost projecting from the retina into the vitreous cavity. And it looked as if an abscess was breaking through into the vitreous cavity. And all the while, we were sure to get the material for the microbiological evaluation as well. And we also obtained a chunk through this dense whitish tissue. Another important step in the surgery I would like to highlight is that these patients had a lot of vitreous cells and colonies, which were actually entangled in the anterior hyaloid. And you see this is a phakic patient, and it's always very tricky situation to remove the anterior hyaloid while doing the vitrectomy. And I'm trying to carefully engage the anterior hyaloid in the vitreous cutter port, and then try to pull it down towards the disc. And while doing that, you can start your cutting and then achieve a clearing of the anterior hyaloid. So you can see now the retina looks pretty okay. And once we see the entire lesion, we could see that there was an associated temporal retinal detachment and a few retinal folds. And this was a large subretinal abscess essentially. So we completed the vitrectomy, and we gave in the intravitreal voriconazole as well as the vancomycin, and also opted to use a primary silicone oil, which we very often do in very severe fungal cases, particularly endogenous endophthalmitis cases. And you can see here, I'm trying to debride the subretinal abscess, which is breaking through into the vitreous cavity. The material which was sent, the vitreous, the bacterial culture did not show any growth. The KOH presentation showed fungal elements. The chalcophore white stain also showed fungal elements, and the fungal culture actually came out as isolates of the bipolaris fungal infection. And it's basically showed presence of pale brown pigmented pseudo-septate fusiform route-ended conidia, which was suggestive of the bipolaris species. And you can see the stain showing the filaments and the beautiful picture of the bipolaris species. So this is a very, very rare fungal infection, which is seen. Postoperatively, the patient showed a stable posterior pole with an oil-filled eye. And the most important thing to note in these kind of infections, particularly fungal infections, the patients have to be put on oral antifungals for a very prolonged time, even postoperatively. These are the post-op fundus pictures. You can see the oil-filled eye showing a very nice retina and the fungal abscess kind of a thing, which is slowly resolving, and a few retinal folds developing 3 weeks postoperatively. So we like to present this case because the bipolaris fungal infection is extremely rare. It's cosmopolitan in nature and it's basically isolated from the plant debris in the soil. There are 3 species, the Specifera, Australiensis, and Hawaiiensis, and it can infect both the immunocompetent as well as the immunocompromised. And it causes a variety of ocular infections ranging from keratitis to endophthalmitis, osteomyelitis, peritonitis, fungemia, and even pulmonary and bronchopulmonary disease. The main essential treatment involves the use of voriconazole, which is very effective against the bipolaris species, both systemically and intravitreally. However, amphotericin B and itraconazole orally have also been used in the treatment of bipolaris. But as suggested in all severe fungal infections, surgical debridement as early as possible gives us very good results. Going through the literature, just 2 or 3 published reports of the bipolaris infection as far as the retina and the eye are concerned. This was a series of 5 eyes from 17 treated with intravitreal triamcinolone in diabetic cases which developed these disease, and also a rare bilateral case, bipolaris Hawaiian, seen in a patient, immunocompromised patient having HIV disease. And they were eventually treated with both systemic as well as intravitreal infections. Since then, we've had 6 eyes in 4 patients, of which 4 underwent vitrectomy. Unfortunately, they developed, many of them developed PVR and had to undergo repeat vitrectomy. Recently, there have been many published papers, particularly from India, of endogenous endophthalmitis. And these are very nice 3 case series of presumed fungal endogenous endophthalmitis in COVID patients. And majority of them have either filamentous or candida species. We also compiled our series, and we are lucky this paper is just coming out. It just got accepted last week. And we've compiled a series of about 6 cases, and it's going to come out soon in Ocular Immunology and Inflammation. It's in press. So we feel that these are rare cases presenting as subretinal abscess, and we strongly believe that very early vitrectomy with primary silicone oil, and we actually like to do a very good, not only the anterior hyaloid, but we also like to do a complete vitrectomy inducing the posterior hyaloid dissection, unlike our endophthalmitis cases. And we are very, very aggressive with our systemic as well as intravitreal therapy. Many a times we might have to repeat the intravitreal therapy even in the presence of silicone oil, because these are very, very dangerous and tough cases to treat. So thank you very much. And I'm sure you will have many questions to discuss, as Dr. Cheung presented earlier. And we are seeing more and more, actually, after these 6 cases since last 2 weeks, we've seen 6 more cases presenting as bilateral cases with different severities. So hopefully in the future, we'll present a larger case series. Thank you very much.
Thank you very much, Dr. Banker. That's really important to learn about these cases. Do you think there is anything that can be done to prevent, or it is the patients are so sick and they need those systemic therapy that put them at risk?
Right. So since the onset of mucormycosis, it's almost like a second epidemic that we are having in my part of the country. It started I'm in Ahmedabad, the city, which is the biggest city in Western India, Gujarat. And the wave of mucormycosis started from our state, and it was almost an epidemic. So initially it was thought that it's mainly common in diabetic patients who are hospitalized for long or who are ventilated, who are receiving oxygen for prolonged time, and because the oxygen mask causes a lot of humidity. But since then, we have a lot of young patients who have been on home treatment, who are non-diabetic, absolutely healthy. So even these patients are developing very severe mucormycosis. And what the infectious disease experts think that it is this Delta strain, which is actually the contributing factor. They make these patients more prone to mucormycosis. So it's not just the additional risk factors like diabetes or humidity or prolonged oxygenation, but it's also the Delta variant itself, which is causing more of the infections. So yeah, we have to be very aware. And I'm glad that so many patients are coming to me just for screening, because there are so many papers in the newspapers, so many articles, that any patient who have had COVID, they just come to our clinics as doctor, just check my eyes. I hope I don't have the black fungus.
So after their recovery, so-called, how long would they be at risk for? How long do we have to continue screening them after?
So we've seen cases as long as developing infections 2 months post recovery of the COVID. So, this is the longest that I've seen. I've seen plenty of these cases developing 1 month, but the longest is 2 months post complete recovery of COVID. And, recovery means the patient is absolutely fine. He does not have any comorbidity, so-called. And then suddenly develops loss of vision and redness and, just comes to me. So
that's scary.
Very scary.
Well, that's really a very important message, so that everyone can be aware of it and look for it. So I've got a question here on the chat. So Manwai asked, did the abscess show up on B scan?
Yes, it did. I'm sorry I did not put up the B scan. We did the B scan and it showed a huge sub-retinal abscess. And that is how we actually anticipated that it's going to be mainly it's a localized sub-retinal abscess. And we've operated 5 cases so far with the sub-retinal abscess type. And we've operated 6 more showing a diffuse vitreous haze with white fluffy ball opacities.
Okay. Mark, have you seen anything, I suppose, hopefully not so devastating in Australia?
As I say, we've had very little of it. We've been very lucky.
That's good.
Yeah.
That's not a complaint.
Down in Victoria, they had a bit, but in Sydney, we had very few deaths, just a handful. So we didn't have acute patients.
Mm-hmm.
Sounds like.
So maybe can I ask more generally? So Ali, so when these patients, I suppose when they've recovered from the COVID, when they come into OT, is there any other precaution when you intubate in terms of spreading COVID? So there are 2 categories, one that are supposed to be not spreading the infection and some that are actually still infectious. So how do you deal with those?
Luckily or unluckily, whatever you call it, we've not had a chance to operate any patients who have had an active COVID infection so far. So all the cases that we've operated, they are those who have recovered from the active COVID. And it's a protocol here by the government that we have to get an RT-PCR test within 3 days of the surgery. So all these cases have returned a negative RT-PCR COVID test prior to entry into the OR. But I've heard from my colleagues who have operated even patients who have had active COVID infections, and it's not just endophthalmitis, but they would be having a rhegmatogenous RD or cases like that. And it's just that they take the special precautions like we are doing. What we've been told by our societies is to have the OTs to have an exhaust fan on the opposite side, or you keep the OT door open and have the air circulate and not closed chamber air conditioning. So, and of course you have to have the full PPE while you're doing the surgeries. So that's the precaution essentially that we are taking.
Yeah, thanks. Okay. And maybe I'll just a few last minutes. In your part of the world, how have you seen COVID affecting the general care of your retina patients? Like, I suppose mostly is the AMD and the diabetics.
Oh, it's been terrible. We've had 3 major lockdowns, and the recent past wave that was very, very severe. So we were not totally shut down this time, but yes, it affected a lot because a majority of the patients were scared to come out of the house. And unfortunately, because of the severity of the Delta strain, I would say almost 80% of the families had almost 1 or more cases in their family. So this time the fear factor was so much that the patients just refused to come for their routine consultations or injections. And we are seeing that now, that since the lockdown has been reduced, we are seeing patients coming to us for follow-up. And you see the recurrences in AMD and the diabetics coming to us with vitreous hemorrhages or the fractional detachments worsening. So definitely it has impacted their vision and the disease severity as well.
Yes, yeah, I agree. And in Australia, Mark?
It's just, as I say, we've seen very little. It hasn't been, we've escaped this one, unfortunately. So far.
And how about in Singapore? Is it affected the routine consultations or?
Yeah, so luckily many of our on treatment patients are still coming, but undeniably a proportion of them have not come, and we have seen a collection of cases that have come back with sub-retinal hemorrhages and lost vision. So yeah, I suppose the longer it drags on, the more we're going to have this problem. So something to keep an eye on.
We did do an FRB analysis of this. So we found some interesting findings. Firstly, we found that it was just really, if you looked at about a dozen countries you operate in Europe, and Singapore was one, the disruption only in terms of injections only occurred for about 6 to 8 weeks around the time of the lockdown. Then most people were able to resume what seemed to be fairly normal services. The eyes with AMD, there was a noticeable, small but noticeable reduction in vision in that cohort, but the eyes with diabetic retinopathy and retinal vein occlusion didn't seem to suffer. So, it does make sense to prioritize the AMD eyes. I think there's evidence for that in this situation. But it wasn't as bad as we thought it might have been. Even initially, they seemed to recover within about 8 weeks.
Mm. So as long as it's not a sustained kind of disruption, so that's good to know. Yeah. Great. Okay. So, and then I suppose that goes back to the point that you made earlier on, Mark, about treat and extend. So in this context, that's another good reason to keep the patients on treatment when they appear, because in case the next appointment gets disrupted, at least we've got a level of protection in there. Okay, so on that note, I think we look forward to, it's been a very enjoyable session on a pinch of the posterior segment. I hope we've learned serious scientific facts, but hopefully it's also been a good fun and quite a diverse topics and discussion as well. So I would say that what we need next is a pinch of sugar and sweetness in the posterior segment after this discussion about the effects of COVID. So it's been my pleasure to be joined again by my good friends, Professor Mark Gillies and Dr. Alay Banker. And I thank you all for attending this session on a pinch of the posterior segment. And please continue to enjoy the Cake and Pie Expo. Bye-bye.
Thank you. Bye-bye. Thank you very much. Thank you. Cheers.
Cheers,
Bye.
Mark.
Yes.